Dr. Rakhi Agarwal, please. Yeah. She is number 17 on the list.
Excuse me, sir, I am here. Amit Thade. Yes.
Okay. You can do it after.
Good afternoon, everybody. I am here to explain my topic, the effect of dexmedetomidine as an adjuvant in brachial plexus block under the guidance of Dr. Jayendra Singh Makwana and Dr. Indu Chadda of BJ Medical College, Ahmedabad. So we all know supraclavicular route was introduced by Kulnam Kampf in Germany in 1911. It is one of the most commonly performed peripheral nerve block for upper extremity surgeries, and it achieves ideal operating conditions. My study was to study the effect of dexmedetomidine for onset and duration of sensory and motor block, in the duration of the analgesia, level of sedation, hemodynamic parameters, and complications if any. This diagram shows the relation of the brachial plexus with the subclavian artery. It lies posterolateral to the subclavian artery over the first rib. Though dexmedetomidine has been approved by FDA only for ICU sedation, but animal studies have shown its efficacy in perineural and intrathecal blocks. So after taking ethics committee approval from our hospital, we took 40 patients of ASA grade 1 and 2 of age 18 to 60 years and weighing 50 to 60 kg, posted for elective forearm surgery, mainly for orthopedic surgeries. It was a randomized controlled trial. We took two groups. In the test group, we took injection bupivacaine 0.5% 20 ml and injection lignocaine 2% 10 ml with undiluted injection dexmedetomidine 50 microgram, that is 0.5 ml. And in the control group, we added injection normal saline 0.5 ml instead of the injection dexmedetomidine. The supraclavicular approach for brachial plexus block was used, and the study was done by peripheral nerve stimulation technique. After negative aspiration of the blood, the drug was injected, local anesthetic was injected. This diagram shows the anatomy of the brachial plexus, the landmarks for the supraclavicular block, and the position of the patient. The effect of block was assessed every 5 minutes for the first 30 minutes. The sensory block was assessed by a traumatic pinprick method, and the motor block was assessed by a 4-point scale, which was graded from grade 0 to grade 3. The vitals were measured every 5 minutes till 30 minutes, and then every 15 minutes till completion of the surgery, and then hourly till the completion of the study. The level of sedation was assessed after 15 minutes by a modified Wilson score. It suggests the score 1 suggests the fully awake patient which follows the verbal command. Score 2 suggests the patient is drowsy and arousable to the command. Score 3 suggests the patient is arousable to the mild physical stimulation such as earlobe tug, and score 4 suggests the patient is not arousable to mild physical stimulation. We exclude the patients if they are not giving consent, if there is any documented local allergy to the local anesthetic, if there is significant neurological disease to the upper limb, if there is history of psychiatric illness, the pregnant and lactating mothers, patients with bleeding disorders or on anticoagulants, patients with significant systemic disorder, and if the effect of block is not complete. We found the results that the time of onset of sensory and motor block is reduced with the test group, which was statistically significant. Same we have shown in this bar diagram. And the duration of sensory and motor block and analgesia was significantly prolonged with test group. It was around 10 to 11 hours with motor block as compared to the 4 hours with control group. The sensory duration was around 12 to 13 hours with test group as compared to the 5 to 6 hours with control group, and the duration of analgesia was around 15 to 16 hours with test group as compared to the 6 to 8 hours with normal saline group. There was a sedation score of around 2 in the test group, and there was no sedation in the control group, so we used the injection midazolam as sedation in every patient in normal saline group. So same we have shown in this bar diagram, which shows that there is significant prolongation of the sensory and motor block and analgesia in the dexmed group. So to discuss, I would first like to discuss why did we select the dexmedetomidine. So the alpha-2 agonistic activity of the dexmedetomidine is 8 times that of clonidine. So it has a better hemodynamic stability, better sedation without any respiratory depression, longer duration of action, improved quality of block, and it possesses excellent analgesic properties. Its mechanism of action is likely to be multifactorial. Its hypnotic and supraspinal analgesic effects are mediated by noradrenergic neurons via hyperpolarization, which leads to the inhibition of the norepinephrine release and its associated activity in the descending medullo-spinal noradrenergic pathway. It suppresses the neuronal firing in the locus ceruleus of the brainstem. Its vasoconstriction effects are because of the alpha-2b receptors, which leads to the delay of the local anesthetic drug. The direct effect, it has a direct effect on the peripheral nerve activity and has some anti-inflammatory effect also. The central analgesic effects are to the locus coeruleus nucleus in the brainstem. These are the various sites of the dexmedetomidine as we discussed. This diagram is taken from the different study which compares the clonidine and dexmedetomidine in terms of sensory motor block and analgesia, which shows that with dexmed the duration is significantly increased. So to conclude, by addition of the 50 microgram of injection dexmedetomidine with the local anesthetic in supraclavicular brachial plexus block shortens the onset time of the sensory and the motor block. It improves the block quality by increasing the sensory and motor block duration. It increases the interval to first analgesic use. It has a better hemodynamic stability, and it decreases the requirement of the sedative medication in the intraoperative procedures. These are the references that we got. Thank you.
Thank you very much for the study. Other studies have already looked at
Yes.
dexmedetomidine and brachial plexus block. Do you feel that the data adds anything?
Sir,
what is new in your study? Any new information that comes out from the study?
Sir, the doses are different in different studies. The 50 microgram dose that we used, it shows excellent hemodynamic stability. We did not get any bradycardia or hypotension episodes, and the duration was also significantly good. Duration of sensory and motor blockade and analgesia.
And for the dose, how do you pick that dose versus I read that many people use 1 mics per kilo.
Yes, sir.
Is that what more or less?
So first we actually started with 100 microgram dexmedetomidine, but the effect was around 24 hours, more than 24 hours, sensory and motor blockade effect. So, and there was episodes of bradycardia also. There was no episode of hypotension, but bradycardia was there. So we gradually reduced the dose till 50 micrograms.
So you've done a pilot study, then you decide this is the best dose to use?
Actually, sir, not much patients, but 5-6 patients with the 100 microgram. Then we concluded that to better to reduce the dose.
So also you post in your discussion that this may be a central analgesic effect.
Sir,
how do you differentiate this from a systemic effect without a systemic control group?
Actually, the analgesic effects are after intravenous absorption, and there are peripheral receptors or alpha-2 receptors. So the analgesic peripheral receptors also cause the analgesic effect, and the central also cause. Locus coeruleus also leads to the analgesic effect. So the peripheral receptors probably has a role for analgesia. Alpha-2 receptors.
In order to answer that question, you may need a third group to show the duration in it. Is that as an IV or a systemic injection to look at the duration compared to the perineural injection?
Sorry?
Does that make sense to you?
Sorry, sir?
You may need a third group in order to answer
Yes,
that
sir,
question,
right.
whether it's a systemic effect of the
Yes, right.
dexmedetomidine.
I should have done it.
Whether alpha-2 agonists bring about their action through peripheral receptors or not is not yet conclusively proven, not even in animal studies. So that's what Professor Chan was trying to tell you.
Okay.
So you should have had another group to differentiate between the systemic
Intravenous
action and the possible peripheral action of this particular drug.
Definitely.
Thank you.
Thank you, sir.